Welcome to the Dr. Doug Show, your resource for bone health, hormone optimization, and women's health span through midlife and beyond. Today, I've got a big topic for you. So we're going to talk about estrogen and we're going to talk about breast cancer because we are now seeing a second generation of women, millions of women who have been impacted by this strong belief in the medical community that estrogen causes breast cancer. And real quickly, if you haven't heard of this, the Women's Health Initiative, which is a very large trial that was published initially, one of the publications in 2002, single-handedly changed the landscape of hormone optimization and replacement. What I want to do here today is critically review this study. I want to review subsequent studies by both the Women's Health Initiative Research Group and other researchers and come to a conclusion to make you feel comfortable about the idea that estrogen plays a role in breast cancer, but how strong is the actual causation? I want to talk about what the studies show. Let's talk about how causative it is, or is it actually protective? What are the other factors that you can consider? So stick around because this is a really, really important topic. And if you are in these two generations of women that have been affected by this belief that estrogen causes breast cancer, you're going to want to listen to this.
3, 2, 1.
Here we go!
So prior to the early 2000s, estrogen was used for a lot of things. So it was hailed as the answer to menopause symptoms, but it was also sold as sort of an anti-aging drug. It was given for heart disease prevention and for cancer prevention. And there were a lot of concerns around the way that estrogen was being sold to the public. And so there was a need to do some well-designed studies. So one such study called the Women's Health Initiative, which is very well known in this space, in addition to a number of other studies that were done in other countries like the Million Women study and other studies, were aimed at looking at the role of estrogen or hormone replacement with combined estrogen and some form of progesterone, and the risk of heart disease for one, but also for other things like breast cancer, colon cancer, blood clot, stroke, fractures, because it had been talked about in context of all of these things. So now the Women's Health Initiative was a massive study. So specifically, though, with hormone replacement, there were two arms to this study. So this is a placebo-controlled trial, and there were two groups of hormone-related intervention. So there was an estrogen group and then a combined group. But important to point out here that the estrogen group that we're talking about here, we're using an oral estrogen that was derived from horses. So this is called Premarin. And Premarin was very popular at the time. It was sort of the standard of care. So it makes sense that that's what they would use. It has since fallen out of favor some, but it is certainly still available. And then the progesterone product that they used was not progesterone. They used medroxyprogesterone acetate, or MPA, which is known as one of many now progestins. So as I move forward through this, I'll talk about progestins. Those are synthetic progesterones. Those are not the same thing as micronized oral progesterone, which is a bioidentical form of progesterone. So there was a group that had both of those things for women that still had a uterus, and then there was a group that had undergone hysterectomy that was given estrogen alone, and that was that oral Premarin alone. Now, the entire Women's Health Initiative, again, was a massive study, over 160,000 women, costing over $625 million. So when people ask, they say, well, when am I going to see the double-blind, placebo-controlled trial for this supplement or this, lifestyle thing? And the truth is that you're not, because they're extremely expensive. And to have a big enough study to show small differences like this study shows, it's going to cost hundreds of millions of dollars, and somebody has to be able to make that money back, or it's funded by the federal government, and they have only, so much money and only so much interest. All right, so specifically this group of combined hormone replacement, so the progestin and the oral estrogen, was run for a little over 5 years. And it was stopped early because they met some endpoints that were concerning for an increase in risk associated with the intervention. And this was built into the study. So some people took this as, there was some emergency and there were unexpected findings. That's not true. These termination points are kind of built in. And so they reached one of these termination points and thought, okay, well, we're not seeing the benefit that we think we're seeing, and it is unethical to continue. We need to stop this trial. But if you dig into the data, it's kind of interesting how this was built in. And so if you look at what they said in the 2002 study publication, they said that all-cause mortality was not affected. So that's good. And then there were certain things that they were concerned about. So coronary heart disease, or CHD, did go up just slightly. So there was a mild increased risk of CHD, which was listed as a 29% increase, and that's a statistical relative increase. And then invasive breast cancer, so that's a big one. So I'm gonna say that again. Invasive breast cancer was increased, but not statistically significantly relevant, meaning that the statistics showed a 26% increase in the intervention group, meaning those who were on hormone replacement, but it did not reach statistical significance. In other words, the confidence interval still was right at 1. And so it did not reach statistical significance. Easy for me to say. Stroke and pulmonary embolism, another type of blood clot, were also elevated, and that was significant. A couple of good things, though. Hip fracture was reduced by 34% and colorectal cancer additionally by 37%. So some big reductions in some good things like colorectal cancer and hip fracture, but some concern for some things that reached statistical significance around blood clot. And then again, breast cancer was not statistically significant, but was certainly a trend. So, okay, let's stop the study. But then my concern was after reading this, later, of course, I was in medical school when this came out. And the takeaway was, well, estrogen causes breast cancer. But I didn't read the study because I was studying to be an orthopedic surgeon and I didn't care. Never thought I'd be in this place. But the takeaway certainly for most of my peers and for doctors that were practicing is estrogen causes breast cancer. But the truth is that they didn't really say that. It also wasn't statistically significant. And so what I wish would have happened is I wish the study would have come out and it sort of said, hey, we need to ask additional questions. And we have this second arm of this study that hasn't come out yet that we are still ongoing. Let's wait for this to come out before we jump to any conclusions around estrogen. Because remember, the second arm of the study had over 10,000 women who were enrolled and were either on placebo or on an oral estrogen without the synthetic progesterone. So this study went on for about another 2 years, stopped at an average of 6.8 years. And this one was also stopped early, but it was stopped early because it didn't look like they were going to achieve statistical significance on an improvement in coronary heart disease, which was their primary endpoint. They realized, hey, it's not going to be ethical for us to continue this study. We need to terminate it, not because there was too much increased risk, but they weren't seeing the benefit that the study was designed to see. So they stopped it early. Then they looked at all the data, and what they found is that the risk of coronary heart disease was not increased, but it was not decreased. The risk of colorectal cancer was similarly decreased in this group as it was in the other, and the risk of hip fracture, again, similarly decreased. So great reduction in hip fracture, great reduction in colorectal cancer. And then as far as blood clot goes, there was a trend towards an increase, but there was nothing statistically significant there. And then there's the breast cancer data. So the breast cancer data are really interesting. So the breast cancer data would show that there was a protection from this estrogen. I'm going to say it again. The estrogen, an oral estrogen in Premarin, was protective of breast cancer. Now, it was not statistically significant, but it was nearly as statistically significant as the increase in breast cancer in the combined group in the other study. So again, what was the takeaway here? Well, the takeaway, because again, I was in medical school, and the takeaway was estrogen causes breast cancer. But that's not what the data show. The data shows that estrogen was as protective on this side as it was potentially risking in the combined side. And so to a thousandth of a point, statistically, they were similar in protection and at risk. So if that were the case, then wouldn't you think that we would at least want to ask more questions, or potentially it wasn't the estrogen at all, it was probably the synthetic progesterone, the progestin. So there's a lot more to talk about here because, again, this was in the early 2000s. The fallout here, though, was dramatic. So millions of women across the United States and then ultimately across the world were taken off of hormone replacement. And what I've seen in my practice, because now I am working in the space of working with women with osteoporosis and hormone challenges in their 50s, 60s, and 70s, this is a group of women that were denied hormone therapy because they thought there was too much risk around estrogen and breast cancer. Yet this single study really didn't show that. In fact, if anything, it showed that the synthetic progesterone was likely the culprit, but that wouldn't bear out in the literature until later. And yet millions of women were ripped off of their hormone replacement. There was so much undue suffering as a result of the misinterpretation of these data. So we're going to go through the newer studies because a lot of studies have come out since 2004. So we're going to go through the newer studies, compare those to the Women's Health Initiative, and come up with a conclusion here at the end. But before we do that, if you are interested in seeing how I put together a bone health program, or how we look at hormone replacement as a comprehensive solution, consider our masterclasses. We have 2 free masterclasses, one specifically for bone health, one specifically for hormone health. Look in the description if you're watching this on YouTube. If you're listening to this on a podcast, then just go to drddouglucas.com for more information on those. Again, totally free resources for anybody who's listening to these messages. So let's fast forward to 2023. So almost 20 years after over 20 years after the first publication, but almost 20 years after the second publication of the Women's Health Initiative, there have been a number of studies published. There have been over 30 critical reviews of the Women's Health Initiative and how the data was interpreted that have been published in peer-reviewed journals. So we're going to look at this study. So this study from 2023 kind of lumps all of these things together. And they look at, and they really do this as sort of like a meta-analysis, and they look at the collaborative group on hormonal factors in breast cancer, and they look at the Million Women study, and they go through all of the data. And what's really challenging about this space is when you're dealing with a study like the Women's Health Initiative, there is so much data. You can statistically manipulate those data in a lot of different ways. And so a lot of these commentaries and these studies that have been published subsequently took the data sets, because they're publicly available, they took the data sets, looked at them in various ways, and different authors come to different conclusions. But this is the conclusion of this study from 2023. And it says, based on the randomized clinical trials, estrogen therapy for women with prior hysterectomy, meaning they've had their uterus taken out, decreases breast cancer incidence and mortality. In contrast, estrogen plus progestin increases breast cancer incidence, which persists through 2 decades. Women considering estrogen plus progestin use for vasomotor symptoms should understand the breast cancer risk. So what's the takeaway there? The takeaway there is that estrogen, according to this study, is protective. Estrogen plus progestin increases the risk of breast cancer and likely other things. So let's look into this a little bit deeper, because that's kind of a big leap. Now, to be fair, that's actually how I looked at the Women's Health Initiative to begin with. And I think that should have been the takeaway, but that certainly isn't what's happened over the last 20 years. So then let's look at this a little bit deeper and understand how this could possibly be the case. So if we look at this 4th study here, this is a study that's looking at the gene expression. And so for those who don't understand genetics, so gene expression, our genes are all the same, person to person. The genes that are expressed are based off of those things that we are exposed to, whether it be nutrition, stress, the environment, whatever. So different people are going to express different genes. Different exposures are going to express different genes within the same person. Okay, so this study looked at then the gene expression of 30 postmenopausal women exposed to different types of estrogen or combined estrogen and progestin therapy. So the first one was the same Premarin as was in the Women's Health Initiative and Provera. So again, the same compounds that were in the Women's Health Initiative, or a topical estradiol and oral micronized progesterone, which is the bioidentical micronized progesterone. And so this study looked at over 3,000 genes. And what they found is that the combined Premarin and Provera combo changed the expression of the genes related to breast cancer at a quote unquote very highly significant rate, and much more so than the estrogen and micronized progesterone. And their conclusion was that the combined therapy with Premarin and Provera affected breast cancer related genes much, much more than the estradiol and micronized progesterone. So then again, was it the estrogen? Well, let's keep talking about it. So this next study, our 5th study here, was a 2017 Swedish population study. This is a massive cohort study, 290,000 women and 7 years of hormone therapy exposure. They looked at invasive breast cancer, endometrial and ovarian cancers, and they saw that there was an increase of 31% increase in the odds of disease, a 31% increase in odds of disease. But they noted at the end that progestin combined therapy was really driving the increased risk, but there was a little bit of increased odds with estrogen only therapy. So we'll talk a little bit more about that estrogen only therapy increased risk, because we keep seeing this signal. It just sort of keeps popping up every now and then. But they also noted at the end of this study, which I thought was kind of interesting, is they said, well, that slight increased risk of breast cancer will be balanced by the significantly reduced risk of GI cancers, which in countries like Sweden are actually more prevalent than in the US. So then we can keep going and we can look at more studies. So here's a 2022 case-controlled study on 43,000 cases of breast cancer. So now this is kind of a different way of looking at it, because breast cancer, even though it's common, if you were to study big parts of the population, you wouldn't actually see that many cases, right? 1 in 7 to 1 in 8 women will develop breast cancer over the course of their lifetime. But if you look at a large chunk of people over the course of 5 years, 10 years, how many cases will you actually see? Not that many. And so doing a case study where you actually look at the cancers themselves, now we can look at that group of people that develop cancer and then compare them to people that haven't developed cancer and look at the increased risk associated with hormone replacement therapy that way. And so they did just that, and hormone therapy was associated with an increased risk of breast cancer, 12% increased odds of breast cancer. But again, formulation matters. Estrogen derived from animals, the same thing, Premarin, or bioidentical estrogen, the estradiol alone, was not associated with breast cancer. The micronized progesterone was not associated with breast cancer, but the synthetic progesterone, the progestins, were, with a 28% increased odds. And so their conclusion is although menopausal hormone replacement therapy use appears to be associated with the overall increased risk of breast cancer, this risk appears predominantly mediated through formulations containing synthetic progestins. So again, form matters and route matters. We'll talk about route for other things later, topical versus oral. So at this point, you might be saying to yourself, well, clearly I don't want to use the synthetic progesterone, but most of the studies have been done on that. So if I use something else, are they actually going to do what I want them to do? That's a great question. So our 7th study here was a 2022 meta-analysis that looked at 74 publications comparing micronized progesterone to progestins and showed that they are equally effective at preventing endometrial hyperplasia, which is in the traditional medical model, the only reason why we give progesterone is so that you don't develop hypertrophy inside the uterus and potentially increase risk of uterine cancers. I think there are other reasons to use progesterone, but they showed that in this case, that micronized progesterone was similar and probably better than the synthetic progestin, and not only for that not developing hypertrophy, but also there were better outcomes from a cardiovascular and breast cancer perspective. They also noted that progestin was not as good as the micronized progesterone at preventing age-related cognitive decline and bone fractures. They also noted that estradiol alone versus the conjugated equine estrogen, the Premarin, has similar or better risk profile for blood clot, which also makes sense because we know that oral estrogens will increase the risk of blood clot over topical. And then also topical estrogen, estradiol may protect better related to cognitive decline and bone fractures versus the Premarin. So that's really good to know. So again, this will show that not only are they likely safer, but estradiol and micronized progesterone are likely going to be as effective, if not more effective, for the things that we actually care about. All right, so here's another topic that people will bring up often when they discuss the literature, and this is a totally valid concern, which is the Women's Health Initiative talked about cases of breast cancer. Now, this is a different conversation than, say, mortality from breast cancer or dying from breast cancer. Now, I wouldn't wish a case of breast cancer on anybody, but understanding the difference between increased identification of cancer versus dying of cancer is an important thing to study. So there was this study from 2016 from Finland that looked at over 89,000 women on hormone replacement and followed them for 15 years and looked for breast cancer death. Now, again, this is a different type of study because now we're following not just diagnosis, because there's some potential bias in people that are on hormone replacement therapy getting more mammograms, and therefore the incidence of diagnosis might actually be higher just because of that. It might have nothing to do with the hormone replacement. But if you follow them to death, then now we're going to look and see what actually happened to these people that were identified as having breast cancer. And what was interesting here is that mortality was actually reduced in all hormone therapy users, regardless of the exposure duration. But they saw that the people that were on the synthetic progestins actually had less benefit, and there were also more cases. Some nice notes here is that age of initiation was not associated with breast cancer mortality, meaning that it didn't matter if you started early or late. So there were some interesting things to take away here, but the biggest takeaway was that hormone replacement therapy did not increase the risk of breast cancer death. But again, I wouldn't wish a breast cancer case on anybody. So all of that said, you might be wondering, but gosh, my doctor still says that hormones cause cancer. How could that be? Well, let me run through a couple of the studies that they're going to hang their hats on if they're an anti-estrogen type of person. Because there are some studies that show this, and I want to talk about this so that we're not just presenting my biased perspective, we're presenting all the evidence that is related to estrogen and cancer risk. All right, so there are a couple of big studies actually that point these things out, and one is this 2020 observational study. This is our ninth study, and this was on almost 100,000 women. And so they were age matched to controls, and they compared users with never users of estrogen and looked at the association of the increased risk of breast cancer. Now, estrogen alone was associated with a 15% increased risk of breast cancer. Estrogen and artificial progesterone was associated with an 80% increased risk. So again, the form matters. A couple other points here is that past estrogen use was not associated with an increased risk of breast cancer, meaning that if you've been on it and you came off of it, you didn't need to necessarily worry about that. Past short-term use of both estrogen and progestin was also not associated with an increased odds of developing cancer, but past long-term use with progestin was associated with an increased odds of developing breast cancer. So again, the progestin seemed particularly nasty. But then they went on to say that yes, it causes an increased odds of developing cancer, but you would expect in this study, if you were on estradiol, or an oral estrogen, that you would see 3 cancers per 10,000 woman years for younger patients and 8 for older patients. Those same data in the synthetic progesterone group were 9 and 36. And the only reason why I bring that up is that statistically, that's not a lot of cases. Again, every case matters, but it's not a lot of cases. And how clinically relevant is it if you're taking it for some reason that you really need to take it for, like say osteoporosis, something that you know that you have. So this is where decision-making is really important. And then the last study we're going to talk about is this Million Women study. So this was a really big study, and the timing of this was really, really critical. So it came out shortly after the Women's Health Initiative. So this was a study from the UK, and again, it included over 1 million women. And it just added fuel to the fire because the Women's Health Initiative came out and then this study came out. And basically what they showed is that users of hormone replacement therapy were more likely to develop breast cancer with a 66% increase in an odds of developing breast cancer and a 22% increase in odds of dying from it. What? So, you could say, oh my gosh, this massive cohort showed these big increased risks. That's a big problem, right? They went on to say in this study that past users were not at increased risk. And well, that's a nice takeaway, I guess. And then they went on to say that if you were on estrogen only, there was a 30% increased odds of having a breast cancer diagnosis. And then if you were on, again, the synthetic progesterone, the progestins, that you had a 100% increased risk. So it seems like the ratio between the two was similar. As we've seen in other studies, there were just bigger numbers. And so how do I explain that? When people ask me about this study, which isn't very common, but when people ask me about this study, how do I explain it? And the truth is, I am not smart enough to look at those statistics and poke holes at them. But fortunately, there are people that are. And so this last kind of rebuttal study, the study 11, is a 2012 basically statistical argument. And this is a group of researchers that basically looked at some of these big studies and said, the way that they're doing the statistics is silly. And so what they said in conclusion is that despite the massive size of the Million Women study, the findings for the progestin group and for the estrogen alone group did not adequately satisfy the criteria of time order, information bias, detection bias, confounding, statistical stability, and strength of association, duration response, internal consistency, external consistency, or biological plausibility. Now, this is why I say that I'm not smart enough to understand this, because there's so many different ways to look at statistics, especially in these really, really big studies. So they go on to say that had detection bias resulted in the identification in women aged 50 to 55, that there would be 0.3 additional cases of breast cancer in the estrogen group, and 1.2 in the estrogen plus progestin group, and that's per 1,000 patients per year, so 0.03%. And it would have nullified the apparent risks reported. And so they actually did a similar study on the Women's Health Initiative, which we don't need to go through. So the challenge here is there is evidence to support both sides of the argument. I think clearly we can see from the data that progestins, the synthetic progesterone, sometimes called progestagens do increase the risk of breast cancer and other complications of HRT. But what about estrogen? What about estradiol? So estradiol has been found in these studies to be related both to an increased risk and a decreased risk. If you were to look at all the studies and do the statistics, I don't know where it would balance out. But I think of it like this, and this is what I tell my patients. Breast cancer occurs, like I said earlier, in 1 out of 7 to 1 out of 8 women during their lifetime. If you were to do a study and apply estrogen to a large group of women, and some of them are going to develop breast cancer no matter what, that breast cancer, if it's hormone sensitive, is likely to grow faster. So here's what I think is happening, is that the population that is given a hormone that develops breast cancer anyway is going to see it faster on imaging than the women who are not on a hormone replacement and not on hormones, because they're just simply going to grow faster. If they're hormone sensitive, they're going to get bigger faster. They're going to be seen on imaging quicker. So this is really hard to isolate and control for in a study. And so that's why I think for me in my practice, I tell my patients that I don't think estradiol causes breast cancer. I think progestins likely cause breast cancer, but I don't think estradiol causes breast cancer. I think it will make a hormone-sensitive cancer grow faster. And if you are at high risk, then this becomes this challenging conversation to say, well, is it worth it or not if you're already at high risk? And that's where the conversation needs to really be focused on, not just to say estrogen causes breast cancer. What is their reason for taking estradiol? Do they have symptoms of menopause? Do they have osteoporosis? What is the actual risk versus the actual benefit? And if you don't understand the risks, it's hard to have that conversation as a doctor. So what we do then is for people that meet our criteria, we use an estradiol cream, we use micronized progesterone capsules, and we use testosterone cream. Because remember, testosterone cream is also protective, very protective of breast cancer. And maybe that was the missing ingredient for all those studies. We'll never know, because I don't think we're going to see any big studies on the trio of hormone replacement like we recommend it. So, okay, I think that's enough. I think we beat this horse to death. This is a challenging topic, and it's challenging to find the right type of provider to have this conversation with, because again, most providers don't really understand the risks like somebody who is steeped in this data does. So that's it for now. Remember, my friends, that you are created for greatness. So seek optimal, not average. Don't be afraid to be extraordinary, because you are, and that's what it takes. Couple of quick announcements. If you haven't already, please subscribe to this channel. It will help other people looking for hormone and bone health related things to find this channel. If you've already been to our master classes and you need more, because let's face it, you might just need more, consider joining our HealthSpan Nation. HealthSpan Nation is an inexpensive opportunity to chat with me and my team on a weekly basis, to ask questions in a weekly Q&A style Zoom. You also have access to our community of people in the HealthSpan Nation, supporting each other and elevating each other, having the same goals and the same challenges as one another. And it's a really, really beautiful community. And then lastly, you have access to our content vault and our discount codes that come out of our podcast here in our YouTube channel. So you would have access to those things above and beyond what you see on YouTube. So you can check all of those things out at drdouglucas.com. I'll see you in the next video. This presentation is for general informational purposes only, does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient relationship is formed. The use of this information and the materials linked to this presentation are at the user's own risk. The content in this presentation is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay obtaining medical advice for any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.